So of course I'd like to, as they get settled in, invite people up with the questions or comments that they might have. There were a number of things that really struck me that were common across the presentations. I mentioned one of them in terms of figuring out the right, not only the right dose, I mean the right thing to give, but making sure that it's in the right form and given the right way. And it also struck me how much issues of inflammation came across each topic as well, and the effect that that has on special nutritional requirements. So why don't I go ahead and invite questions to come up, and when people are thinking of their questions. I actually had sort of a cross-cutting question, which is, as I was listening to the presentations and hearing about the nutrition requirements, it really struck me, and again, this was a conversation many of us had at lunch, was that we tend to just, check levels in blood, in plasma or serum, whatever it is, that you measure these things in. But really, oftentimes, we want levels in the tissue, which is obviously hard to come by, especially if we're interested in the brain. But I'd be interested in hearing your thoughts about that and how we overcome these issues and if there are biomarkers on the horizon. So Martha, that one obviously was kind of targeted towards you, but the others can.
So I think, especially when you're talking about tissues that are difficult to sample, that you have to begin some of the discovery-based work in animal models. And you have to understand the biology and then the sort of surrogate biomarker that you can find in the CSF. Or there are biomarkers that are found in blood that report on, they should be in your brain, and they leak essentially into your blood. And so there are biomarkers, but we don't really understand if those report on, we understand that they report on barrier breakdown, but we don't know anything about their relationship to nutrition. And so I really do think this has to be driven by mechanistic studies that we then translate.
Yes, Barbara Schneemann. So I was struck, I guess particularly in the presentation on cystic fibrosis, and I think maybe it affects the IBD, and I'm not sure about the kidney and the brain barrier, blood barrier, that when you look at, as we've understood better and better the nature of the metabolic problem, there's not a nutrient directly involved in the metabolic problem phase. And in the context of this workshop, it makes me ask the question of, can you have a special nutrient requirement when you're looking at a metabolic problem that doesn't really directly involve a nutrient? Is it just a matter of having to account for the absorption problem, so you just provide enough to get us past the absorption problem? Or is there another way of thinking about the special nutrient requirement as it's impacted by the metabolic state?
Is this on? Okay. I think at least for CF, I think it's more complex than just malabsorption. I think nutrients are also being affected by the CFTR abnormality itself. I think that I also think inflammation is a big factor here. That you're looking at a utilization abnormality as well as an abnormality in quantity. So I don't think you can just take a plate of food and double it and feed it to people with CF and everything will be okay. I think you have to take into account the digestive and absorptive matrix abnormalities in the GI tract. It's not just a matter of increase and everything will be all right.
I think the question is a very good, pertinent question. I know this the workshop is about special nutrient requirements, And when I think nutrient, I think clearly the classically described nutrients are the macronutrients, the micronutrients. When we think about the differences in the different food products we consume, very different now than 50 years ago. Again, perhaps these are not appropriately classified as nutrients, but they're components of our diet. And I think that's an important distinction to make. I think we have to better understand that. If you talk to a food scientist, and I think it's extremely illustrative for us as nutrition practitioners to talk to a food scientist, they know how to design foods, and there's a lot of additives that go into our foods. And are these biologically active? Potentially, yes. Do we study them in our arenas? No. I think for something like inflammatory bowel disease, I think chronic inflammatory conditions that don't have a clear-cut etiology, I describe kind of the pathogenesis, but the exact mechanism is not clear. I think we have to think a little bit more broadly when we think about nutrients and food components.
So this is a question for Dr. Lee. Actually, it's interesting that you should say that because I graduated from Cornell with a degree in nutrition back in 1982. Went to get a PhD in toxicology, and I wanted to study the effects of food additives on health, and it didn't exist anywhere at that time. So I did inhalation toxicology. But anyway, that aside, you had put up a slide for risk factors versus protective factors with regard to nutrients for inflammatory bowel disease. And I was wondering if there's any kind of evidence that has separated these factors for triggering the disease versus these factors for either maintaining remission or making the disease worse or things along those lines.
And before you answer, I'm going to take my prerogative. To help with the transcription later, can you say your name for the record?
Jill Ryer-Powder, sorry.
Thank you. It's my one job.
It's a good question. So I'll say one important limitation of those sort of risk factors, protective factors, these are large epidemiological studies, and as a lot of us in the room know, these are from like food frequency questionnaires, and these are sort of not good in terms of high quality, detailed assessment of dietary data, but it's pretty good if you're trying to quantify sort of exposures of longer periods of time, and it's a major limitation in our dietary studies here. Like these epidemiological studies, there's going to be a lot of confounding involved, and there's potentially sort of, you've got to really be able to control for sort of, if you are a big meat eater, you're probably going to be consuming a lot of omega-6 fatty acids and things like that. You may be less likely to be consuming a lot of fruits and vegetables. The studies that have been done epidemiologically, many of them are sort of risk of development of disease, and others are also for sort of what's the risk of relapse. So I kind of intermingled the two in there, but predominantly demonstrated sort of risk of developing disease. But I think they're probably intermingled in terms of those risk factors and protective factors that I listed probably are equally pertinent for sort of inception of disease and treatment.
Okay, thank you.
Claudia Morris from Emory. This question is for Martha Field. Question about the folate deficiency in the brain. So and the need for folinic acid or methylfolate. Is there a problem in conversion from folate to folinic acid, and is that metabolic or environmental? Because I'm just thinking that we seem to be seeing so much more of this in children these days.
That's a very good question. So the conversion of folic acid to the reduced form is saturable. It probably varies by individuals. And so just the process of conversion makes it very hard to get blood folate levels high enough to overcome that energetic barrier. So I don't think that there's also the worry that at such very high levels you'd have to use, and again, this is very high. This is, in the few small studies that have tried it, they're well above the UL. There is gastrointestinal toxicity, nephrotoxicity associated with those high levels. And so this is not really in the normal exposure range. I don't think it's about folic acid per se, although the one concern is that because of that tight binding of folic acid to the receptor, it may, and there's really not good evidence for this, it may impede the transport of other folate from the blood to the serum. But I don't think it's necessarily about folic acid itself.
Patrick Stover, Texas A&M University. My question is for Dr. Lee, but it may be relevant to any of the other panelists. But specifically for the intestine, Is there evidence that any of these nutritional therapies actually change the cellular composition of the intestine, increasing goblet cell or decreasing goblet cell concentrations? And is that one of the mechanisms whereby you see some improvement? But it could be relevant to other organs as well. But to what degree do these therapies change the cellular composition of the organ?
It's a great question you ask. So studies have looked at dietary therapy, changes in the microbiome, and changes in inflammation. We know for sure that when you change the diet dramatically, you have alterations in the microbiome. At the same time, there is improvement in inflammation here. So exactly the causality is not completely easy to decipher. When you have recovery of the GI tract function, you should have improvement in the epithelial integrity, normalization of goblet cells, etc. I think it's a little bit difficult to sort out, and I think maybe Dr. Gary Wu may be able to better answer that question tomorrow in terms of at the cellular level. But for right now, we know that there are large changes occurring. Exactly what the mechanism is needs further study.
Yeah, just from the kidney disease, and I was visiting in University of Illinois in Urbana-Champaign and talking to some of my colleagues, and one of them was actually looking at the absorption of proteins in patients with kidney disease versus non-kidney disease, and we were looking at the results. And when he started the study, I was very skeptical. I said, there's no need for uremia to really affect the gut. I mean, patients with diabetes have gastroparesis and other things, and they may not be able to absorb. But for me, this is a very straightforward question you're asking, and it's wasting your time. And he just showed me data that there's about a 20% less absorption of proteins in patients with ESRD on dialysis. We do not know. I'm like, why did this happen? I have no idea. I mean, it's well-matched, well-done study with feeding and isotopes. So there is something that really affects in the setting of chronic kidney disease. I would say I would put everything into this same basket. Like if I don't know why it's something happening, I say it's inflammation. So I'll put that in number one. And then number two would be my second basket, which is uremic toxins, which I don't know what they are. But there is something happening. And again, in the setting of this complex diseases such as IBD or others, there has to be something that influences, because everything talks to each other. There's an effect.
Thank you very much.
Denise Ney, University of Wisconsin-Madison. I have a question for Dr. Kisler. I was very impressed with the commonality of chronic kidney disease in our population, that it's associated with obesity and, of course, diabetes, and also that the flip and the switch on how much protein you need to prevent it versus once you get on dialysis. So my question relates to upcoming changes in protein requirements for the DRI. Now, my understanding is that now that we've moved away from nitrogen balance to more stable isotope and other methods to look at protein requirements, as well as a greater understanding of protein requirements in our aging population, which no longer seem to go down as lean body mass goes down, I think this evidence would suggest that the DRI for protein is going to go up with future examination, although that hasn't been decided yet. How do you think this fits with prevention of chronic kidney disease in a population where the majority of people are overweight and obese?
Yeah, I think you're just making an excellent point, and a dilemma that we've been dealing for years to really put it into context of what should we recommend. I'm not going to tell you this is the solution, but I would say I think as we look at these DRIs and RDAs and other things, these are designed to really give a lot of guidance to the general population, and we're dealing with individuals that are at risk. I think we're in the era of precision medicine in the sense of we really need to think about individuals rather than just giving a generalized one-size-fits-all approach and say this is good for everyone. I mean, I think we need as a public to really make these general recommendations and be aware of what diet needs to be like. But if you're an individual at risk, and again, we are to examine and find those individuals, I will say, from my own perspective, just to give you an example, obese individuals that are prone to diabetes should not eat high protein. That is simple as that. But what we do is, in general, you go out to marketing and this and that, everybody eats all these high protein bars in their hands, and that's the treatment for obesity, which is a risk. If you're an African American and if you have diabetes, you should not eat too much protein because that really puts you at risk. An individual that is actually lean at the age of 40 has no predisposition to any disease and exercise, just can eat. So I think that's where the dilemma happens. I'm sorry, I don't have the straightforward answer to you, but I think we need to move ahead of this everybody gets this and everything is okay concept to, I think we need to think about the patient's individual background, and you can say anything, you can put anything in environment, genes, diet, and everything else, and make the recommendations accordingly.
Right. And in a sense, what I hear you suggesting is that perhaps obesity itself is a biomarker for having a different protein requirement to prevent
absolutely, absolutely. I think obese people should be very careful with what they eat, and they cannot go out and assume that they're the same as other individuals because they're at risk. And this is a very important thing for kidney disease, at least. There's data accumulated that's very strong. No, we're not going to do a randomized trial of being obese and not obese. But I can tell you that there's quite convincing epidemiological data that is a risk factor for other diseases to come.
Thank you.
Dr. Can I push on that a little bit? So I think that was an interesting comment about diabetes and protein. So ideally in a situation where somebody is predisposed to diabetes or has diabetes, they need to pull back on their total calories, have an appropriate distribution of macronutrients. So in this setting, to suggest that focusing on protein itself is a problem, if they pull back on calories and there's an appropriate focus on protein, that's okay?
I would assume so. And again, we were talking about the research gaps. We always think about the dietary protein intake in terms of total intake. Mm-hmm. I think there's also, we all deal with this in the dietary food frequencies and everything else. % of what you eat is also important, how much you really change. There's also data to suggest that if you increase the % of protein in the overall diet, that might be detrimental to you. So if you can just sort of spread it out equally and cut back on the overall calories, you might be in a better shape for a diabetic or a pre-diabetic or obese or overweight individual.
That's great.
Hi, this is Sue Berry from Minneapolis again. And I'd like to bring back up Alex's overlay and overreaching question about the impact of dysregulation by inflammation, which is a common theme that we have heard in almost every one of these presentations, whether we're talking about inborn errors or kidney disease or inflammatory bowel disease or CF, and how inflammation subverts, if you will, the nutritional process. Would any of you care to comment a little further on that? So I'll leave it open to you. Thank you.
I can start from this side, and you can go this way.
Actually, everybody can comment on that.
We can all comment on that. And there's a group of individuals in the kidney disease world who are interested in nutrition metabolism, who believe is the evil of everything. Inflammation is the reason why we feel these patients are so sick, and that's why they die. And there's also a group of individuals who say that's just a bystander. Every chronic disease is associated with inflammatory response. Again, the only way to really figure that out is to give anti-inflammatory interventions to see if your target outcome is improved or not. And in the setting of kidney disease, I can tell you there are a few studies, if any, including our own, to suggest that if you give an anti-inflammatory intervention, you can improve the overall nutritional state. There are a few studies that suggest that if you give the right medication, and again, here for chronic disease states, I have to be very careful. The simple, non-specific anti-inflammatory drugs such as omega-3 or vitamins and this and that are highly unlikely to be effective because the mechanism is more complex. If you take a specific anti-cytokine, you can actually drop the inflammatory process. The CRP and IL-6 and IL-1 go down if you give an IL-1 receptor blocker, if you give an IL-6 receptor blocker. These new targeted therapies actually work. Whether that translates into an improved protein turnover, for example, has not been shown. Very few studies, if any, in a couple of patients or so. Whether that change, if it were true, reflect a better outcome, that is also not shown. Is it going to improve frailty? Is it going to improve overall well-being? Is it going to improve depression? Is it going to improve heart disease? Is it going to make people live longer? These are really tough questions to ask. Until we get there, we're still going to put, as I do, anything I don't know, it's because of inflammation. It's right there.
I'm a little hesitant to comment, given that I'm not a clinician, but I would just say that I think there is, at least with respect to what I spoke about, there is a connection between inflammation and deterioration of the blood-brain barrier. And it's well known that inflammation causes nutrient catabolism. But there was a really nice review that came out that showed the effect of anti-inflammatory medications on levels of other nutrients. And so I think that's going to be a really hard thing to tease apart.
I'll comment briefly on inflammation in the GI tract, which can lead to systemic inflammation. So it's well established in animal models that if you give animals a high-fat diet, you can induce intestinal inflammation, sort of experimentally. I think it's important for us as we think about nutrients and inflammation. So if you do a study in humans and you measure fat in the diet, it's going to be very different across individuals dependent upon the other, I think, matrix of nutrients is what was described earlier. So the different nutrients that are consumed. If I consume a steak per day, that's going to be very different if I have steak and a single baked potato versus steak and a rigorous amount of vegetables, for example. And I think as we study how nutrients can impact disease, I think it's really important for us to think about how to do these methodologies appropriately and not focus on single nutrients, but focus on sort of patterns of dietary intake, how foods interact with each other. And I feel that this is very important. As a clinician, I learn about specific nutrients and that's it. But thinking about how nutrients can interact together, I think that's a very wide open field and important for us as we think about how chronic diseases are on the rise.
I can't add much to what's been said, but I will add the dimension of time. And I think that's one of the things that you mentioned and that we saw years ago when we did some studies in neonates with sepsis, that the inflammation and the resultant protein catabolism extended far beyond the time when the child was sick. You're patting yourself on the back. You think you've done such an awesome job. But if you're checking for catabolism, it's still occurring. And I think that we've emphasized chronic disease today, so it's not a surprise that the inflammation is still having an impact. But I think the bigger issue is that inflammation is having an impact sometimes far after you think you have things tied up. Our patients with CF who have an exacerbation and go in the hospital can often develop more inflammation and diabetes during that period of time. Their diabetes doesn't go away when the exacerbation goes away. It goes away 3 months later. And so I think there's a dimension of time here that we have to be cautious about.
Thank you. That was a swell discussion of inflammation, which I couldn't resist saying. Sorry.
Actually, I stood up to ask Martha a specific question, which I will, but this discussion of inflammation, again, coming back to the context of this workshop, it's some of the comments, I think, relate to how we need to be thinking about inflammation as we think about recommendations for the general population. And the challenge that this workshop is faced with is when does that state lead to a special nutrient requirement? When does it go outside of the normal population and into a state where we really need to rethink what the nutrient requirements are? That said, you can comment on that if you choose, but my specific question was about the folate and just whether or not you're thinking of those high levels. Are you really looking at a drug at that point? You're actually treating something as opposed to dealing with a nutrient requirement issue?
That's a good question. And so I think it's important to keep in mind that the disease, the barrier breakdown changes the nutrient requirement. So it becomes very hard to concentrate folate and maybe other nutrients as well. And so as a result of the disease, whether it's inflammation, Alzheimer's, the breakdown of the barrier does change the requirement. And so I don't think it's acting as a drug in that case.
Alison Steiber from the Academy. of Nutrition and Dietetics. I want to kind of connect dots and get your input on thinking about how we identify nutrition status, because as I listen to the four panelists, people talk in different ways about how they identify malnutrition or a nutrition deficiency or excess. And I think this is a pervasive problem in the area of nutrition, that we don't have a unified way of thinking about malnutrition. And so if we're going to talk about nutrition requirements, then we need to know when you're not meeting them in a way that we're all diagnosing the same. And someone might say, well, we have biomarkers of serum albumin or prealbumin, but really those are so greatly impacted by inflammation. And as we just heard, inflammation is across all these different conditions and many, many others, that really isn't a reliable way to assess nutrition status, at least for protein and calorie needs. And so I just like a thoughtful discussion on how we're assessing nutrition status in these patients from a macronutrient standpoint. I think it's different in a micronutrient standpoint.
I'll start because I'm not convinced that we can achieve your goal. I think that just going through the lens of cystic fibrosis, I'm not certain that there is an overarching definition of malnutrition that will describe malnutrition in every chronic disease or every major disease. I think the standards are going to be a bit different, and what I would react to as a clinician as malnutrition will be a bit different depending upon the disease process. I'm not sure. Go ahead.
As a pediatric gastroenterologist, so growth and development extremely important, and so in the pediatric realm. Pediatrician as well?
I'm a pediatric gastroenterologist.
Oh, okay, guys. So we're the same. So we're talking the same language then. So.
Be careful.
So I mean, I'll be extra careful with my response. And Dr. Stallings is in the front. So I mean, we have criteria to diagnose malnutrition. They're sort of very broad, general criteria based upon weight for length Z-scores, BMI Z-scores, and sort of weight loss over time. These are very broad, general things, but clearly they're going to miss a significant amount of individuals with a lack of nutrition. So I think the comment from earlier today about sort of a nutrition-focused physical exam, that's going to pick up things that these sort of anthropometric measurements don't pick up, and I think it requires astute clinicians and dietitians thinking about sort of the trajectory for children as we try to identify nutrition and appropriately sort of supplement. I think understanding the disease process as well so important, because you cannot sort of apply these same criteria across disease processes.
I'm going to take the moderator's prerogative and stop this question just so we have time for the final question.
So I just want to make one comment about the microbiome and dysbiosis. We're all really excited about the microbiome. No one knows exactly what it means or what it does, but we're starting to clarify specific microbial components. And Dr. Lee, thank you for pointing out it's not bacteria going through the lamina propria, it's microbial components or breakdown products. So with regard to the two pediatric gastroenterologists on the panel, is there a way to formulate a food matrix that contains specific functional proteins or pectins or different components that bind to these micro components or feeds the microbiome in a certain way to develop short-chain fatty acids for certain conditions, but essentially deals with not necessarily a macro micronutrient, but rather a functional component in food that the disease demands be given as a distinct nutritional requirement? What are your thoughts?
I think it's a great question you ask, and I think it's something that we are attempting to better understand pathophysiology and sort of how dietary changes impact the microbiome, how the microbiome interacts with the host, the healthy host versus the inflamed diseased host. I think it's a great question to ask. I think we're definitely looking towards that. If we can, for example, in the future say we've made the diagnosis of this disease condition, Crohn's disease, and you have this microbial signature, you have this genetic sort of profile. Is there a particular way that we can impact your microbiome, understanding that when you are exposed to this dietary component, this is how you as a individual who has this genetic backdrop are going to sort of synthesize and metabolize this nutrient in the setting of this dysbiosis? I think it's a wonderful question you ask, and in the future, I would love if, for example, as 10, 15 years down the road, if I was able to tell my patients, okay, we're going to have to start you on some medications concurrently. This is exactly the dietary therapy we'd recommend because we feel that this can sort of, in an adjunctive fashion, help optimize your healing from this intestinal inflammatory condition. Great question. I think we definitely are not close to that, but I think we're aiming towards that. And again, I think understanding how food components interact, that'll help us to understand how to engineer things thoughtfully.
Or at least using food components to manage that aspect of a disease.
Well, I'm going to end this session so we have time for our break, but I'd like to thank the panelists for a really wonderful session.